of the renowned pulmonologists in the country to walk us through the session. I invite cordially Dr. Rajam Iyer, who is qualified in MD and Diploma in Palliative Medicine from Cardiff, UK. She is presently serving as the Pulmonology and Palliative Care Consultant with Bharti and Hinduja Hospitals based out of Mumbai. And she is also the winner of prestigious Hargobind Award. So it is indeed our pleasure to have you with us, ma'am, today, and over to you.
Thank you very much for the kind words and the introduction, and a very warm welcome to all of you. It must be quite exhausting to join at the end of a week and end of the day's work. But it's nice to see so many of you gather. And like she mentioned, it's nice to have an interactive session. All of you have had a lot of experience, I'm sure, and we would love to hear those also. And I think the more interactive a session, the more interesting it becomes. So, you know, anytime you have a query, anecdote to share, or some thoughts, just put it on the chat box. And if it is something that we need to discuss, we'll do that at the end of the session, where you can unmute yourself and we can have a discussion. But so we request it to be as interactive as possible. And just to clarify, wanted to check with all of you, what is the number, I mean, in this training session, which is this lecture number that you all have, and how familiar are you with what we are hoping to train you with? Can you let me know? So how many days have they had the sessions for?
This is the 12th session, ma'am.
Okay, so this is the 12th session, which means they've had it for quite some time. And I will also keep a eye on the chat box. I will request you also to please highlight any issues if you think is of a burning need to be addressed immediately.
Sure.
So, like the topic says, today, the topic for today is going to be the scope and need for respiratory palliative care. And I think post-pandemic, this has become a even more important topic. It was always a very important topic, but I think the pandemic has made it even more necessary that all doctors and all healthcare professionals are trained in palliative care in respiratory diseases. I think it becomes important also to address this issue, because somewhere in the minds of doctors, nurses, healthcare professionals, as well as the common public, palliative care is focused on end of life, and palliative care is focused for cancer patients. And the whole purpose of today's topic is going to bust both those myths. Palliative care is not just for cancer patients, and palliative care is definitely not only for the end of life. So just to emphasize on what I'm trying to say, if you see the statistics of number of Indians affected by various conditions, you will see a dramatic rise, and a dramatic rise of non-communicable diseases, which I usually conveniently change it to non-cancer diseases. So if you see, a large bulk of Indians are affected by conditions like diabetes, hypertension, heart disease, tuberculosis, respiratory diseases, cerebrovascular accidents, etc. So cancer does feature in the list. And yes, we do add 1 million new cancer patients every year to our list. But look at the amount of Indians who suffer from non-communicable diseases, which you will agree are incurable. They are only controllable, and therefore they also have a period of time which is unpredictable. The course is unpredictable, it is only controllable, and they do have a up and down phase in their non-cancer conditions. So because of the fact that Indians have almost 40 to 50% of Indians are affected by these lifestyle diseases which cannot be cured, it becomes very important to focus on hand-holding of the patients as well as the caregivers and addressing their health-related suffering. which by definition of palliative care, you will agree that as palliative care physicians, we address health-related suffering of patients and caregivers, which means we offer them a holistic view and holistic care, not just control of physical symptoms. Coming specifically to respiratory conditions, we have documented evidence that worldwide there is an increase in the instance of interstitial lung disease and COPD, particularly so in India. And in India, unfortunately, even infectious disease like tuberculosis, with the advent of multi-drug resistant, extremely drug resistant, and total drug resistant tuberculosis, it has become a challenging infectious disease to treat. And at some times we only have palliative care to support the patients and family. So the main focus of all the conditions that we see in respiratory diseases, the curable ones are the infections, like in any other system, while the airway disease like asthma, COPD, bronchiectasis, and the parenchymal disease of various causes of interstitial lung disease, as well as incurable or untreatable tuberculosis, fits into the purview of palliative care diseases. Now, I'm sure all of you have actually seen this graph, of how people across the world die. So if you've seen this graph, it's got a great reference also in the proposed trajectories of the way the population of the world dies. There are 4 essential graphs, and it's important for you to remember that graph number 1, only 7% of people undergo sudden death. So 7% of people are the ones who enjoy a good quality of life and then suddenly die. The graph B represents those patients who probably can be compared to having cancer. So they enjoy a decent quality of life and then they have a slow, slippery slide to death. But please do remember that in cancer, we have done enough research and there are predictable indicators for prognosticating end of life. For example, survival, stage of the disease, the patient's performance status. So many things contribute to predicting and able to prognosticate the end of life. Come to graph C, which is going to be the focus of our talk today, where any organ failure, these patients are diagnosed fairly early in life, say diabetes, hypertension, COPD, etc., at probably 60, 65. Then they lead a prolonged period of time till they reach their death, which could be anything between 10 to 15 years in COPD. And what do we see? They have a gradual decline in their quality of life. Their life is punctuated by acute exacerbations and hospitalizations with every dip. And therefore, these people live a very unpredictable course. They live a long period of time with a very high symptom burden. And the most difficult part is that non-communicable diseases, COPD, interstitial lung, congestive cardiac failure, dementia, Parkinson's, these patients do not perceive these illnesses and conditions as a life-limiting and life-threatening illness. It is, for example, if you diagnose somebody to have lung cancer vis-a-vis COPD, the patient with whom you have disclosed the diagnosis of lung cancer immediately starts thinking of how much time do I have? What do I have to do? But if you diagnose somebody to have COPD, that is not the first thing that comes to his head. It is not perceived as life-limiting. And unfortunately, these patients live a very long period of time with high symptom burden. And you must remember that we as hospital physicians and doctors only meet these patients in the acute exacerbations when they come to hospital. What happens to these patients when they go home? Are they able to walk? Are they able to feed? Are they going to the toilet? Are they able to self-care? We don't know their quality of life because we are so focused on only the quantity and to save them and to send them home. So therefore, it becomes very important that all chronic illnesses, and COVID has proven even acute illnesses, require the hand-holding of a palliative care team, which is very important to alleviate health-related suffering of the patient and the caregivers. It's very important to realize that health is not just physical. It has to be mental, emotional, psychological, social, financial in our country, as well as spiritual. So again, to highlight the need of palliative care in respiratory diseases, any chronic illness can be compared to falling off a skyscraper. As the patient is falling, we need to prepare the patient's family and the patient about the deteriorating health, and therefore help them process, analyze, and prepare for end of life. We as doctors in our training are not trained to talk, are not trained to talk at all about death and dying. So what happens is we reach a situation where the patient is already on the first floor. The manner in which you fall, land depends on the way you fall. So if the fall is punctuated with sensitive, unhurried, timely conversations about conditions like COPD, interstitial lung, motor neuron disease, dementia, Parkinson's, where there is no treatment, right? We know. So whose responsibility is it to tell the patients the trajectory of their illness? It has to be our onus to foresee and foretell. Yes, it is not easy. Yes, it is very, very difficult to talk to a patient about this, but it is important to give them time to process and analyze. When the patient is already on the first floor and you tell them, sorry, I cannot do anything, that is the most devastating thing for a patient and a family to hear. This patient and a family, especially if it's an incurable progressive illness, must start listening to this. Be prepared to listen to this for a long period of time, till when you can actually say that really we can only offer him comfort. I cannot offer a curative option. So this is our dream, that palliative care is integrated in all specialties in MBBS curriculum, where we are taught how to talk to patients. We are taught how to prepare patients for death, because that is one certainty in life, and a bad death is avoidable. And we integrate palliative care along with curative care, so that slowly and steadily, when curative options are lost, palliative care becomes a smooth transition. It is not that the treating consultant says, my job is over, now she will take care. It is an abandonment of care. Here, it's a smooth transition from curative to palliative, and we also continue to look after the patients at end of life and the patient's family during bereavement. So this is the proposed dream that we need to have. Just like we cannot think of having a hospital without a casualty department, in the years to come, in the next decade or so, every hospital should have a palliative care department, because our patients will die. And what we can then promise is a good quality of life till death. And that is very, very important, to be aligned with the person's interest of how, where, and in which manner he would like to die. Modern medicine doesn't let you die with dignity. It prolongs your miserable quality of life with life prolonging treatments, with unindicated aggressive treatment like artificial ventilation, dialysis, central line, Riles tube feeding. All these are different spectrum of life sustaining treatment. So one very common thing that pulmonologists ask is, when do you start talking about these difficult things with patients? If you do it too early, patients are going to run away. If you do it too late, well, it's too late and the patient is already endured. So there is this research that has been done in England about what is the best timing to start these difficult conversations and dialogues with patients. And that is, if the patient has come to your casualty, if your OPD, in your mind, in the consulting, you think, will you be surprised if this patient is dead in the next 1 year or will not be alive? If the answer to that question in your mind is that the patient might not be alive, it is time for you to start proactive palliative care. So that is the cutoff point. When you feel this patient is not going to be alive the next year, that gives you enough time to build rapport, find out how much the patient knows about his illness, give him the truth about his illness, speak to his family, prepare his family, give them time to process, and slowly reach your goals of care. How would you like to be treated in an emergency? Where would you like to be treated in an emergency? These are the difficult questions you need to ask. And the more you practice, the second nature it comes to you to talk to patients. And it's extremely satisfying to do exactly what the patient desires. And it's very, relieving to see the stress-free relatives. Okay, any questions or anything on the chat box? Chaitanya Malik has asked, would a separate department be counterproductive? I have not understood this question. So if you could please clarify, do you want to unmute and clarify right away?
Yes, I'll do that, ma'am.
Yes.
In medical colleges, having a separate department may be a good idea, but the majority of our health system is on PHCs, subcenters, CHCs, and
No, I'm
district
talking of
hospitals.
district hospitals.
And
I'm talking
no,
of hospitals.
right?
Yeah, tell me.
No,
Yeah.
yeah. So for in a district hospitals, where in, for example, in this state of Chhattisgarh, where more than 90% specialists are not there, having a separate department will just, shift the responsibility of having this difficult conversation to a separate group of people, be it palliative care nurses or palliative care physicians. Why not integrate from bottoms up as well, would be my counter to having a separate department.
I've not understood the counterproductive bit, but yes, we have to integrate MBBS doctors. We have to train MBBS to have these difficult conversations, and then we need to support them with palliative care specialists in the city. Point is, in a resource crunch country like India, we saw during COVID, we saw even America and England come to their knees. We can't offer ventilator to all, and we shouldn't be in unindicated patients. Imagine a 90-year-old with dementia, with diabetes, with heart failure, with kidney. We have seen these patients do poorly on ventilator with COVID, or for that matter, even with a normal lung infection. The point is selection of patients. It is easier to put a patient on ventilator when available than not to put the patient on ventilator after discussing with family for 2 hours. So I haven't understood the counterproductiveness. Yes, we have to integrate palliative care right from MBBS, and we have started that module, which is the 8Com module, Attitude, Ethics and Communication Skills module, from September 2019. So all 18-year-olds who join to do medicine are now trained to talk about these difficult and understand medical ethics. So definitely it should not be worsening your quantity of work. By introducing palliative care, you actually see to it that you comfort patients who cannot be cured and focus on patients who can be salvaged. Am I making myself clear? I mean, have you understood your point, or any more clarification? Okay to proceed? Chaitanya, okay to go ahead?
Yes,
Yeah,
ma'am, he
yeah.
had responded to it.
Okay, sorry. And coming back to the timing of referral, another easy list of indicators, which is basically when will you actually refer these patients, is there are 2 documents, which is the gold standard framework and the blue maple document, which actually give you indicators for every chronic condition. So for example, in COPD, if the patient is above the age of 75 with any of these 2 indicators, which is recurrent hospital admissions, that is 3 in the past 1 year, worsening breathlessness, which is recorded by the Modified Medical Research Council, fall in lung functions, continuous use of oxygen, 1 ICU admission, or if the patient has multiple comorbidities. So if the patient has even any 2 of these conditions or situations, it is time to start proactive palliative care, because the long-term prognosis of this patient is guarded. So it gives us ample time to talk about these difficult situations with patients. So the 2 documents, I'm sure Pallium India can share it with you, which has criteria for referral to palliative care in every chronic condition, be it kidney, cardiac, renal, neurological, as well as cancer, etc. These 2 are very important documents that one must know so that it becomes easier for you to refer to palliative care. Also, we have shown that statistically, like I told you before, patients with non-cancer hardly get palliative care, and this has been published in this particular journal. And unfortunately, what is important is that these patients who had terminal non-communicable diseases, which are chronic illnesses, and these patients, because of the lack of integration with palliative care, ended up getting more aggressive treatment towards end of life, ended up having lesser symptoms documented and therefore comforted, ended up with more CPR. So the quality of death which is another very important parameter measured, and where India stands 59th amongst the countries of the world, is also very important. How are our patients dying? Isn't it important to see to it that patients die in peace, with dignity, respect, and comfort? And that is something I think we are not being able to focus on, because we treat 19-year-olds and 90-year-olds in the same way. We really need to stop back and think how we are treating our patients. Again, coming to respiratory diseases, even if we admit all patients of acute exacerbation of COPD, very few patients, only 25% of patients are alive and well with a good quality of life after discharge, and almost close to half our patients keep getting readmitted. So they spend the last few years of their life constantly in and out of hospitals. And I'm sure you have heard of enough people, patients and family or family friends, who have gone through this difficult last years of life. Why do we make it more difficult when we know that the illness is incurable and progressive? We need to give patients choices. We need to explain to the patient the full information about their illness with their consent. And then after they're able to understand, process, then do what they want us to do, because it is their life, their body. It has to be their decision, not what you and me think is right for them, because they have to endure the difficult situation towards end of life. Okay. So this is another graph that actually shows you, as the number of years go by, even if these patients get into ICU with COPD, they really don't make it well. Almost 40% of patients are dead within the first 6 months. So are we selecting our patients correctly for the ICU? So coming back to symptoms of respiratory diseases and how we can palliate them. So this list is what we normally do for all patients of respiratory diseases on a detailed history, and after a detailed history and clinical examination, they undergo with chest X-ray, HRCT, blood gas, pulmonary function test, an echocardiogram, ECG, etc., because that is a comprehensive examination list. What we don't realize, we never ask, is what the patient undergoes because of his chronic symptoms of breathlessness. Imagine a patient who is breathless every single minute of his day, every day of the week, and every week of the year. That patient has a sense of frustration, anger, the amount of dependency he has on his family members or caregivers. This person was the one who initially built the family and was the head of the family, has suddenly no role. So imagine what the patient goes through is a social isolation. And actually the patient even probably has a social death even before a physical one. So these are the aspects which completely misses doctors, because we focus on, is your breathlessness better? Are you coughing less? Is the sputum less? Are you able to eat? Are you able to sleep? But what the patient goes through or endures because of his constant symptoms is something we completely miss. So therefore, we need to change the way we ask the history. Instead of saying, are you breathless, or is your breathlessness better or worse? We need to start asking open-ended questions, not closed questions, which you will learn in communication skills. And in order to know how his life has changed because of his illness, we really need to ask him what he has stopped doing to avoid breathlessness, or what would he enjoy doing but is not doing because of the breathlessness. And that is going to open the Pandora's box, that I can't go to the toilet on my own, I can't wash myself, I can't brush my teeth, I can't speak to my family who lives away, or I can't eat with my family. These are small, simple pleasures, or even play with a grandchild because he's totally out of breath. So the simple things in life that he expects to do is something we need to tap with better history taking and open-ended questions. Again, there's a question here, Sridevi. I'm taking a water break.
Yes,
Referring to palliative care itself may be perceived as end of life. And that's exactly what we are here to bust. That this myth that palliative care is end of life is something we really need to work hard. And we in palliative care can share with you immense number of anecdotes and experiences where, by integrating palliative care early, we have actually managed to improve the quality of life. patient is able to spend more quality time with family, patient is able to do what he likes to do, travel, talk, meet, eat, and not be in and out of hospitals. So this is exactly, and it's very unfortunate that even doctors think palliative care is end of life. And that is exactly what we want to change. So Padma hums is that explanatory. We need to realize once you start integrating palliative care in your daily practice, you realize what a great value addition you are to that patient's life by just being there as a friend, as a support. And the beauty of palliative care is the multidisciplinary team. It's not just the doctor, it's actually the nurse, the speech therapist, the physiotherapist, the counselor. They all make a great difference to the quality of life of the patient, because very often doctors are not asked everything by patients. Patients are intimidated to ask doctors silly questions like, I can't walk to the toilet or I can't wash myself. That is where these multidisciplinary team people give the patient a safety net, that the patient can actually then ask the most smallest of questions. Now, no question is small or silly, but whatever might be difficult for him to ask to the doctor, he's able to ask. So this is exactly what we need to do, is change the mindset, paradigm shift of thinking that palliative care is end of life. And this is unfortunately very true. Very often my colleagues say, oh, so you deal only with patients who are death and dying. It's not true. We make a quality difference in their life when they're living, so that they die better and transition better. Like we all must agree that death is inevitable, but a bad death is avoidable. And that's exactly what we want to focus on. So moving ahead, this is another very important model that has been described in literature, which again should be focus of our discussion on respiratory diseases, because all those patients who are breathless because of the underlying pathophysiology, because of the airway disease or the parenchymal disease. These patients end up using accessory muscles of respiration. They have an increased respiratory rate and work of breathing. Now imagine sitting in a room breathless every day, every moment of your life. The one thing that is going to be overactive is your mind. So the anxiety, fear, frustration is only going to keep building up. How is this going to get worse? Will I get bedridden? What am I not going to be able to do more? Those kind of thoughts keep coming in and the patient gets anxious. That feeds into the breathlessness, making him even more breathless. And both these things together make the patient less active, which means he says, oh no, yesterday I walked to the toilet and I got really breathless. So let me not go to the toilet at all. Let me ask for a bedside commode. Let me ask for a pan. So the more and more the patient becomes scared to walk or do any form of exercise, he gets more and more deconditioned. So like the famous saying, if you don't use it, you lose it. So the patient becomes more and more deconditioned. Therefore, he's not even able to do 1-2 steps and gets caught in this vicious cycle of being breathless, therefore getting anxious, therefore getting more breathless, and therefore getting more deconditioned. And palliative care does exactly the breaking of the vicious cycle. Like I told you about the multidisciplinary team, the pulmonologists look after the breathing with medications and non-pharmacological maneuvers. The psychologist or the counselor does a great deal of addressing and allowing the patient to cope with that incurable illness. And the physiotherapist makes the patient useful and helps the patient do activities of daily living with less effort. So we all work as a team. It has to be a holistic approach so that these patients enjoy whatever time they have of good quality life and able to do what they enjoy doing, which might be a very small thing that you and me take for granted, like eating a meal with family or going to the garden and just sitting watching kids play. All this becomes a Herculean task for these patients who are chronically breathless. So that brings me to the definition of what is chronic breathlessness syndrome. And that is very important because these are the patients who are already on optimum treatment for their breathlessness and continue to experience psychosocial, spiritual issues, emotional issues because of their breathlessness, and it actually interferes in their activities of daily living and quality of life. So these are patients who are taking everything possible for their breathlessness and continue to be breathless. Or they say, I walk one step and I'm totally out of breath. Or I keep sitting in the bed and I'm still panting despite the fact that I'm hooked onto oxygen. So these are patients who really need our assistance along with the primary consultant, which is the pulmonologist. So chronic breathlessness syndrome is important to identify by the pulmonologist, but it's very important to integrate a palliative care team so that all these various issues can be addressed and a holistic care can be given to patients. And I cannot emphasize more on how important non-pharmacological maneuvers are in this situation. And this is another important aspect which is not taught to us in medical school. We become expert people in writing prescriptions, but simple things like allaying anxiety, like making the patient breathe better, loose clothes, making the patient sit next to an open window, not crowding the patient, also using a handheld battery operated fan. There is enough research to suggest that just a simple 200 rupee hand operated fan, when blown to the patient's face, really makes the patient comfortable. And it is very, very important. There are enough research papers published on how just blowing a hot handheld fan, and in a country like India, which is quite warm, it really does help the patient to cool down and settle down. Yes, it should be used with a little bit of caution in a COVID patient because again, the aerosol spread. But please remember, in all other patients, it really does make a difference. And then how to make these patients plan their day? They need to pace their activities, prioritize what is important. So for example, if a patient needs to go to the toilet, he can go to the toilet in a wheelchair and then get up and do. So save that energy to get to the toilet. Similarly, go to the park in a wheelchair and then be able to make 1 or 2 rounds with oxygen if that. So we need to plan patients' lives, help them pace correctly, and prioritize what is important. And of course, offering counseling, physiotherapy, all immensely helps the patient tide over an acute breathlessness episode. Please do remember and read up handheld fan in controlling patients with chronic breathlessness. If you're interested in some articles, we are happy to share. So non-pharmacological also helps the caregivers immensely. What to do if the patient is in such a distress? There are lots of things you can list out to the caregivers before panicking and dialing for the ambulance and the GP to rush to the hospital. So very important to try and settle the patient. Then, of course, are the pharmacological measures that all of you know. I really don't have to go about it. If it's an infection, you do antibiotics. Obviously, you do nebulizers, steroids, etc. And of course, we also use oxygen. Now, a word of caution about oxygen. It is a pharmacological drug. It should be given only when indicated. It should not be given if the oxygen levels are more than 88. We need to maintain between 88 and 92 in patients with chronic respiratory illnesses. Therefore, when the patient starts becoming breathless, shoving the nasal cannula is not the solution. If the pulse oximeter shows an oxygen level above 88, you need to try all the non-pharmacological and before you start the patient on oxygen. And usually we do not start if the patient's oxygen levels are above 88. It's below 88 that you need to start oxygen. And another important thing that you, at this point, which I would like to emphasize is the drug morphine, which is extremely beneficial for patients whom we have tried all this and continue to be breathless at rest. And the aim of giving morphine is not like that in pain. It is much smaller doses, never exceeding 30 milligrams a day, and always given with a laxative, but small dose of morphine is very safe and very effective after you have tried all the non-pharmacological as well as all your other pharmacological agents are already going on. And when the patient continues to be breathless, it does improve the quality of life. And what does morphine do? It reduces anxiety. It acts centrally. Therefore, it reduces the respiratory rate. It reduces the work of breathing and therefore helps the patient feel less breathless. the sensation of breathlessness reduces. It doesn't touch the patient's lungs or change the airways or the parenchyma. So it's very important to explain that to the patient and the caregivers. There is a lot of opioid phobia amongst doctors, patients, and caregivers. So we start very low, go slow, and remember that the other medications for the underlying pathophysiology is on. All the other interventions are on, and slow doses of morphine is given. And when we think there is anxiety, we club it along with a benzodiazepine. And when there is a panic attack, we add midazolam. So you can please do remember that your non-pharmacological is important. Your regular pharmacology for that underlying pathophysiology is important. After that, if the patient continues to be breathless, a low dose of morphine is extremely effective. Any questions or any thoughts? The chat is clear. So is it okay for me?
How long we can give it, this morphine?
So if the patient improves the morphine, you can slowly titrate the dose. We usually titrate every 3 or 4 to 5 days, so weekly. If the patient doesn't show improvement, you can stop it. Usually patients continue it lifelong because they feel the quality of life improves. So for example, my patients on morphine say, thank you, doctor, I now could talk to my grandchildren on the phone, or I could go out and have a meal. Now I do that regularly, or I can do physiotherapy now for 20 minutes. So what is important is you need to individualize the patient care. If that particular patients feel better, then you need to titrate the dose accordingly. Morphine does cause constipation. So patients with chronic respiratory diseases cannot afford to be constipated. You must give a laxative, and you also must monitor the improvement. You also, like I said, need to emphasize on non-pharmacological techniques, and you can start initially with SOS on need basis. If the patient is taking 1, 2, 3 doses, then you regularize it with 2.5 is what we start 12 hourly, then 8 hourly, then 6 hourly, and slowly, gradually increase. We never go beyond 25 to 30. It is never needed to go beyond that. Also, you must remember, because it acts centrally, we need to be cautious of a cutoff point. We can't expect the patient to be doped. We want the patient to be awake and comfortable, not doped, or when the patient is still ambivalent. And enough research has suggested that it does not worsen the hypoxemia and it does not worsen the carbon dioxide. Because if the patient has type 2 respiratory failure, obviously we will prescribe a BiPAP. And along with BiPAP, so that the patient cooperates better and his breathlessness is better, is when we advise low dose morphine. So it can be continued till the patient passes away. It can be started, it can be stopped, it can be used initially as an SOS, so that the patient is also convinced that yes, after taking 2.5, I felt better. Once the patient is convinced, half your battle is won, and then you can start 12 hourly, then 8 hourly and 6 hourly with caution, and keep in touch. So I always keep a list of which patients I have started morphine, when I have last contacted them, and weekly I just send them a message or call them so that I know they are fine, or I know they're doing well, and I know they have improved. And believe me, one of the papers, one of the research we recently did on the prescription of morphine, a lot of patients and caregivers were very relieved to see that at least there is something for them to do if the patient really goes out of breath after doing everything else in the book or everything else after we taught them. At least there's something, they can go to have a bath easily, go to the toilet easily, small pleasures of life, like I said, which you and me take it for granted. Any questions on morphine?
I have some doubt. This is
yes.
Now we are discussing role of morphine in respiratory, like
in breathlessness. In breathlessness.
Okay, breathlessness. Okay, that we are giving minimum dose, not for the pain.
Correct. It's very different. The
Yeah,
pathophysiology is different. Yeah.
So without breathlessness, if the patient is having some other problem and with anxiety and associated symptoms like old age diseases, whether we can follow up the.
So those patients need counseling. That's where geriatric psychiatrists. So the patient is elderly, anxious, living alone. Those patients need counseling. If there is no underlying respiratory condition and the patient is not breathless, then
Okay.
they need counseling.
Okay.
Patients with cardiac failure, congestive cardiac, also can be breathless. Morphine does a good job in congestive cardiac failure, ejection fraction 15%, 20%, edema, constantly breathless, multiple ICU admissions, nothing can be done about the heart. You give diuretics, you give oxygen, do the non-pharmacological. If the patient continues to be breathless, you can do. The indication here is on chronic breathlessness syndrome.
Oh,
Okay. Now coming to another important aspect of Shilpa, you want to ask something?
Yes, ma'am. Ma'am, in case there is a patient of CA lung, and for pain, we have put that patient on step 2 drugs, and he or she is like breathless also. And so, is it okay to put that patient on morphine for breathlessness? Like the dose of breathlessness, and continue with step 2 medication?
No, you cannot combine opioids. Dangerous.
Yes, ma'am. That's why. Yeah.
Very dangerous.
So, ma'am, in
then
that
what you
case,
should
what
do,
should?
assess the pain, see what is good for his pain. And if it is, then you can combine step 1 with morphine.
Okay.
So you start step 1 and you do low dose morphine, because breathlessness will come in control with low dose. Pain will not.
Okay. So, ma'am, in that case, morphine will be started 4-hourly dose for pain.
In
and
pain,
with
it will
step
be
1.
started 4-hourly, correct? So,
but ma'am, if we want to take the benefit of like for relieving the breathlessness also.
yeah. So suppose you're starting, if pain is the major symptom and you're starting on the pain dose, it's unlikely that the patient will not have his breathlessness controlled, because breathlessness needs much less dose.
Yes, ma'am.
So if you cannot,
Okay.
you should not combine step 2 with step 3.
Yes,
That
ma'am.
is
Definitely.
not good at all. If
Definitely.
at all, you switch to step 1 for break, and then you can, if the pain is severe, you can start on morphine. Then the medicine dosage required for pain will alleviate the breathlessness.
Okay. Thank you, ma'am.
Because the pain dosage requirement is much higher than
Yes, ma'am.
to alleviate breathlessness.
Thank you.
Okay. Anything else on the chat? Does morphine affect ejection fraction? No, morphine doesn't do anything to the heart or the lung. Morphine only reduces the sensation of breathlessness. So patient with a respiratory rate of 35 or 40 will now start breathing at 20 or 22. And that is a great relief for him. So instead of doing, he will not stop being breathless. He will only feel less breathless. Respiratory rate will decrease. And therefore, the tidal volume will improve. The gas exchange will improve and oxygenation improves. That is the way morphine does. It doesn't do anything to the organs. It is a centrally acting drug. Please remember, it's a narcotic. Okay. Any more questions? Shilpa, your hand is still raised?
No, ma'am.
Okay.
No.
So we need to also talk and just briefly touch terminal breathlessness. And why is this important? Because those patients of ours who have decided not to go to hospital or not to go to the ICU, they still have the right to die comfortably either at home or in the ward. So when a patient is very breathless, end stage, actively dying COPD, actively dying interstitial lung disease, he literally struggles like a fish out of water. Okay. And therefore, these conversations are important to have much before the patient reaches that stage. Because how do we treat terminal breathlessness? Is that patient is not aware and awake of his distressing symptoms. So we give mild doses 24 hours through a syringe pump under the skin, which is subcutaneous, of combination of morphine, midazolam, and if the patient is agitated, we also add haloperidol. So it's a very important thin line of distinction. Very often people will argue that isn't this killing the patient? So this is not euthanasia. Please remember, this is alleviation of symptoms aggressively. The doses we use are so small that it only controls symptoms. The death which is going to occur is due to the underlying illness. So we need to properly select patients. We need to have communicated and documented well, because this patient will now be unresponsive under the influence of morphine and midazolam. And the idea and the intent is transition with dignity, respect, and comfort, and not be aware of his distressing symptoms, jumping on the bed, Patients and relatives also upset, crying. So the whole purpose is, when you know the trajectory of an advanced chronic respiratory disease, which is going to be incurable, you need to, and you have those indicators where the patient is constantly requiring more and more oxygen. The patient is becoming more and more bed bound. The patient is not able to maintain oxygen, like how we even saw in COVID. When the COVID pneumonia became really bad, patient is not maintaining oxygen. His oxygen levels are falling. He is more and more breathless. There is really nothing to do. That is the time we offer this palliative sedation or a combination of midazolam, morphine, plus or minus haloperidol to let the patient transition in peace. So this is another very important thing you need to realize, so that patient has a decent, comfortable transition. Any questions, or shall I go on? Everybody's turned to silence, so maybe it will come later. So
Yeah, it will come in the end.
so I will also just go through these other distressing respiratory symptoms, because it's a part of the talk and it's already 45 minutes, so I don't have much time. So again, cough, which is considered as a normal protective reflux, and it is important so that foreign bodies don't enter. But when it becomes persistent, it can become very irritating and very distressing for the patient and the caregiver, along with all the complications that it brings, like rib fractures, incontinence, hernias, syncopes, etc. The cause is not only respiratory, the cause is gastric, ENT, cardiac, psychogenic, drugs, radiation. All this can cause cough. So your history taking is extremely important. When do you cough? How much do you cough? Do you cough on lying down? Is it dry cough? Is it wet cough? Is it spasmodic? Is it throughout the day? All this makes a difference of where the cough is coming from. So that is first. So you need to identify the cause, and then you need to identify and optimize the treatment. So if it is gastric, the lifestyle changes have to come. Patients has to have early light dinner, go on walk, 3-hour gap, propped up position. Then of course the solution of the cough is probably proton pump inhibitors and anti-reflux medications like domperidone. If it's cardiac, then obviously it is diuretics, it is adjusting the the intake of how much water goes in, etc. So if we have dry persistent cough like those we get in interstitial lung disease, because of the fibrosis, the patient just keeps having a dry hacking cough, then we just need to suppress the cough. Okay. And in such situations, again, we start with codeine. Codeine is a very important drug which is given, again causes constipation. Please remember to prescribe laxative, especially in elderly patients with respiratory conditions. Codeine syrup can be given. Morphine helps in intractable distressing cough, and it's done in the same way as that of breathlessness. Sometimes intractable cough, we've also seen interesting papers where gabapentin, which causes drowsiness in the night as a side effect, helps in reducing cough. So we start with 100 milligrams in the night and make it 300 milligrams when the patient is used to, and we go maximum to 600 milligrams in intractable cough. So please remember, when you have a patient with intractable cough, acknowledge the distress the patient is going through, try and identify where the cough is coming from, suggest lifestyle changes, suggest things like lozenges, hot water. Is it a postnasal drip? Is it a reflux? Is it from the heart? Is it from the lungs? If a patient is a known patient of a chronic advanced lung disease, then focus on how you can remove the cough. So you can tell him to try other things, but codeine, morphine, gabapentin helps the patient relieve the cough and at least have a decent night's rest. Okay. Then pleural effusion. Now again, very common, especially in the setting of cancers. Mostly the distressing pleural effusions are exudates due to TB or malignancy, but certain cardiac failures can also keep coming with transudative effusion. But the important point is recurrently filling pleural effusions. And when you have recurrently filling pleural effusions, the way to manage is by directly focusing on the prognosis of the patient. If the patient is going to have a good prognosis, which is decent, more than 4 weeks, then you can put a small pigtail catheter and let the pleural effusion drain. If the patient's prognosis is bad, if he's terminal, he's bedridden, then you do a one-time aspiration, let debulk the lung, let the patient be comfortable. And for the breathlessness, then you can do a small dose of morphine, because what affects the patient is the breathlessness, but the patient is not going to get off the bed at all because of his malignancy. Then you can just alleviate that symptom and reassure the patient and the family. So always remember, it depends on the size of the fluid, the reason of the fluid, as well as the prognosis. If the patient has a long good prognosis, then we also do procedures like thoracoscopic intervention of talc, slurry, or pleurodesis, where we fuse the pleura, where we drain the fluid, then we put irritants like bleomycin or talc, cause intense inflammation between the visceral and the parietal pleura, and see to that the potential space is obliterated so that the fluid doesn't have place to fill at all. But for this, the patient really needs to have a good prognosis. Okay. Then, of course, is hemoptysis. When it comes to hemoptysis, again, remember that it's not the blood loss that causes the patient's death. Patients can die because of asphyxiating in their own blood. Please remember that patients can drown in their own blood, and that can cause death. And actually speaking, in our country, we see a lot of hemoptysis because of tuberculosis, and it's equally. So it's not even active tuberculosis, but it can be a complication of tuberculosis because it's of the fibrosis, calcification, it eroding the bronchial artery. So please remember that in the lung, you have a dual circulation, the pulmonary and the bronchial, and the bronchial artery circulation is actually at the height, at the level of the blood pressure. So it's the bleeding occurs at the arterial pressure, which we record on patients' arms, which can be torrential bleeding, even if there's a small nick. So it's very important to anticipate which conditions or which patients may have torrential bleeding. For example, if you have an SVC tumor, or if you have a cavitatory squamous cell in the lung, you need to prepare these patients that they may have a torrential bleeding. And therefore, these patients should have a list of emergency contact numbers of hospitals where they might be able to rush, because these interventions are unfortunately done in tertiary hospitals. And what are those interventions? There's a lot of things one can do. One is endoscopic installation of tranexamic acid or adrenaline. One is laser. Then is also cryotherapy. Then you can also do something like bronchial artery embolization, or you can also debulk tumors by stenting. So these are very complicated procedures that are done in tertiary hospitals. So these patients who may have bleeding need to be prepared mentally with a full list of doctors they can contact in case the bleeding happens. So it can happen at any time of the day or night. They should exactly know where to go and therefore be seen ASAP, because hemoptysis can cause fate. It can be fatal. And it's quite scary to see a person die of hemoptysis. So even the caregivers, what we say is to be ready with dark colored towels, because anything in white, the blood looks quite dramatic and quite scary. So even if it is 5 ml, it looks like 500. And it can be quite scary for both the patient. He might see that and die of a shock. Itna khoon, what am I doing? I'm not going to be alive. So it's important to prepare these patients for this kind of situation. So that is also very, very important in hemoptysis. So, and then I just wanted to touch upon the pandemic, because we have all gone through it and we know what a difficult time it was. And I just wish that if all of us had been taught palliative care pre-pandemic, we would have handled it much better amongst ourselves, supporting each other, supporting the patients, supporting the people who have lost lives, those families who have lost multiple people, the complicated grief, the complicated bereavement, and how we learned about COVID, which patients to admit in ICU, which patients to ventilate, which patients to be at home. All these things we learned by making mistakes. If we had palliative care in every hospital, we could have told the elders to stay at home, not bring them. So I have seen 90-year-olds, 86-year-olds on ventilator with COVID. It's heartbreaking to see, because we know the literature from the West, they've never come out of it. So it's very important to learn from this pandemic that palliative care is so important for the mental, physical health, not just of caregivers, patients, but also doctors. Doctors went through so much frustration during the pandemic. It was not easy to pull yourself back and go back to work and do the same rigmarole put your life at risk. There was, in so many hospitals, there was no PPE. There was so much going on in these various hospitals. So it's very important to realize that in COVID patients, ethics, autonomy, are we doing in the patient's best interest? Are we doing something that's harming the patient? And justice. We let 40-year-olds die and 90-year-olds were put on the ventilator. Is that justice? Is that what we have become doctors for? So triaging patients, selecting patients. So you need to have these correct interventions. And therefore, even in patients in the ICU, when patients were actively dying with COVID, did we look after their symptoms? Did we look after their spiritual pain? They could never see their loved ones again. Were we there to handhold them? Yes, a pandemic is a difficult situation, but at least we need to try by seeing to it that the human resources were enough to try and give that patient a decent farewell, because that was the last time to look after that particular patient. So again, withdrawing treatment, that is also very important, because in India, we feel that withdrawing and withholding treatment is unethical, while the Supreme Court has passed the judgment that everything is medically and legally ethical. It is not wrong to withhold a patient from treatment if it is not in the patient's best interest, but communication and documentation is the key. Intent is comfort. Intent is not to kill the patient. So that is very important. We doctors really need to talk, and doctors need to see to it that we are doing what is in the best interest of the patient. And everything is not about, it has to be about the patient's comfort, because without the patient, we really don't have any role. We do not have anybody to doctor with. So please do remember that the needs of people at the end of life is the same, whether it is COVID, whether it is a stroke, whether it is respiratory, whether it is cancer. The dying patient only needs comfort, dignity, respect, support, and the caregivers require support. So with that, I will stop sharing and I'm happy to have some discussion. Questions?
Yeah, there is a question in the chat. As in COVID death, even the next to kin is not allowed for funeral. A lot of emotional trauma being undergone. How come palliative care role in COVID? Yeah, I think you are the best person to answer that question.
No. How come means I didn't get the question.
Dr. Ravi, would you like to just unmute and tell?
There is a lot of stress. The relatives, the caregivers, even the next to the kin, the family members have been undergone emotional trauma by not touching the patient, by not going near to the patient.
Yes.
After the death, it's like something that they are being carried away.
Yes.
Even being far, being far from the places, and it is like allowing them to dead after death. It's like something which many of us can't take it. So at that time, how come the role of palliative care be
like
helpful?
I told you, palliative care is a multidisciplinary team. Okay. So palliative care has people from all walks of life, social workers, volunteers, people who have looked after patients of COVID, patients who, people who have, there are doctors, there are nurses. So counselors really help in palliative care. And that's why all these things, why do you think mental health has become such a big thing after the pandemic? We need counselors. Difficult bereavement and difficult grief has happened for people, and that's how palliative care could have helped each other. I know there are times when I, after a long day's work, used to come home and really not want to see or talk to anybody. It used to be not easy losing one patient after the other. It's a very difficult task to then get up in the morning and go back to that same ward knowing that another 10 death certificates have to be filled. It's very distressing. We all have gone through it. So imagine the patients. And there have been families with multiple losses. It is very difficult to say that in the morning you were a full family and by night there was one father missing, one brother missing. It is a devastating time that everybody around the world went through. So yes, palliative care helps in such a way that hand-holding, that addressing the grief, addressing the bereavement. Therefore, I think we now, all of you with exposure to palliative care, will be able to challenge a next pandemic, which apparently is going to be there for us in our lifetime, much better. Because here you see what happened in the second wave in a place like Delhi, urban city, the complete collapse of the infrastructure. Why did it happen? Because there was unnecessary use and abuse of oxygen. Everybody was panicking. Everybody was rushing to the hospital. There was no selection of patients. And relatives were so edgy. There was nobody to calm them. There was nobody to talk to them. The pandemic, the info pandemic was so much that people with RT-PCR positive was like treated like a death sentence. And the use of steroids, the use of remdesivir, there was absolutely no rational. There was complete chaos in the country. So what I'm trying to say is we need to, therefore, there were so many videos telling ki be rational. Everybody with COVID is not going to die. But there was also enough evidence to say that people with comorbidities, people elderly did not make it on the ventilator. So why to subject them? Why to use up our 4 ventilators on 90-year-olds when our 40-year-olds can be saved? So this is the influence of palliative care, the triaging, the selection of patients, talking to patients. Imagine if you went with a relative and were told, sorry, we cannot give you the ventilator, we'll give to a 40-year-old. You will also want to trash up that doctor. But if you are told the reason for not putting the elderly on the ventilator, the futility of aggressive care, why we are not doing, obviously you will also have an understanding. Plus, what is important is comforting and seeing to it that the elderly is not having distressing symptoms at the end of life. So if his breathlessness is taken care of, if his pain is taken care of, if he's allowed to WhatsApp with his family, then at least he's not like tadpoing or he's not struggling and suffering at the end of life. That is important, and that does come with palliative care. So I can say for my own experience, 5 years ago, I was a pulmonologist. I only did pulmonology, but now with palliative care, I've become a much better human and much empathetic and compassionate doctor. I can see people suffering. It's not that they're wasting my time. And now also that I'm a caregiver at home for my elderly parents, you realize how much you go through. If you have one person sick in the house, the whole house is out of order. So imagine our patients. If medicos feel like this, imagine non-medico households. There will be panic at all times. So it's important to acknowledge what the patient, we might not be able to change everything. We are not God. We are not going to say sab kuch theek ho jayega. That's not happening. But at least we are there to support them, handhold them, and be there for them, to listen to them. We don't have solutions for all. Palliative care teaches you to be polite, kind, patient. Look at what happened in Rajasthan. That young doctor was harassed because of that pregnant PPH. See, if we had a palliative care department, the minute that patient would have got admitted, we would have said this patient is a grave prognosis. Because the gynecologist needs to do her job now of delivering the child. She doesn't have the time to handhold. The pulmonologist, the oncologist needs to treat the cancer and needs to do their job. All these other things has to be done, but has to be done in a professional manner. And that's why the other name of palliative care is narrative medicine. Like you do a procedure, communication, when done well, is like a procedure. If one had prepared those relatives, they would have anticipated that this outcome of this PPH pregnancy is going to be disastrous. We all need to learn to talk. It's very, very important. And that is not focused in our training. We do not have a single session of communication in our MBBS or MD training. So if you have an MD teacher who says, in my experience, you should go on the ventilator, that's what we learn. But it is not we who go on the ventilator, it's the patient. So we need to give the patient a choice. Imagine tomorrow, if I am the patient and the ICU says, I will put you on the ventilator. He is nobody to decide. I have to decide. It's my life. Isn't it? So we need to learn ethics. We need to learn to talk. And we really need to get comfortable thinking and talking about death. We are all very uncomfortable. How many of you are comfortable talking about death? Excellent. I can see one hand go up. Sorry, I'm reaching out for some pani. So there's only one hand going up. A brave hand at that. Yes, Aditi, you want to talk about it, or we have no time? Police, Sridevi?
No, we can.
Okay, ma'am, I believe in a lot in talking about death. to that extent, I was in my final year MD physiology when my granny was having a CA esophagus, and I was about to get married in 3 months, and we spoke about her death, and she just said that I don't want to survive till your marriage. And I said, ma'am, Nani, don't worry, just go. The next day she was no more. And I've already spoken with my parents about their last wishes, what last rites or anything and everything they
Wow.
want. They are very healthy, touch wood right now.
I'm very
But I
relieved.
think, and rather I have made a written note that I don't know if tomorrow I'm walking on the road and I have an accident. I have made my last wishes. So I have been very vocal about death, and that is what I believe in.
It is
And
very relieving because according to
very
me,
relieving.
you need to talk about this when the sea is calm, like you said, when they're
Yes.
healthy. Because in
Yeah.
emergency, during a storm, you end up making all the wrong decisions.
All the wrong decisions, emotional decisions.
And Dr. Rajgopal has once even quoted this, that doctors' parents, doctors themselves have probably the worst deaths in our country because we just don't let go. वेंटिलेटर है, उसके बाद एक्मो भी करेंगे, उसके बाद डायलिसिस भी करेंगे, उसके बाद सब कुछ करेंगे, बट करते रहेंगे, जिंदा चाहिए किसी भी हालत पे. And I can't think of any human being who stands in front of whichever Lord or faith he believes and says, keep me alive with tubes in every orifice, treat my body like a pin cushion, but keep me alive. I don't think any human being, I haven't met any human being who wants to die like that. And yet, the unfortunate statistics is that our ICUs are always full. We never ask the choices. And second thing, only 7% of patients or people die suddenly. So the 93 will go through bed-bound phase, which means modern medicine will only become more and more expert in prolonging poor quality life. So we really need to focus on what quality of life means to our patient. It might not be the same what it means to you. So very important discussion, and thank you for all your contribution. Anubha Mahajan wants to say something. Yes, Anubha.
Ma'am, I just over this conversation only, it talking about end of life and specifically such things turns very difficult. Like I'm saying it from my personal example. My mamu had cancer and he passed away in 2020, and he chose a peaceful death. He was in AIMS. He did not choose to go on the ventilator, rather chose a peaceful death, which was a great thing. But my own family couldn't understand it. His wife couldn't understand it. Despite he himself had conversations, somewhere, I mean, the whole family was still blaming the doctors. It took them 2-3, weeks to come to peace with it. And then I sat with them and we had a conversation, why he took that decision and all. But somewhere there was a lack. They did provide him a.
But did the doctors talk to the family before he chose this?
I know
that is
that
important.
Was the
because
this is the reason.
See, we need to realize that when it comes from professionals before the event, this is exactly advanced care planning. This is the reason why I said you need time. People need to process that. Acha, ye nahi karne se ye hoga, or if this doesn't happen, this will happen. If this happens, he will suffer. So doctors need to emphasize the futility of ventilator aggressive treatment in an advanced cancer patient. How it is important, because same if you talk to families who have lost their patients with cancer with multiple hospital admissions, with multiple lakhs of bills to the corporate hospitals, and they are equally frustrated, saying doctors knew this man is going to die, still they did 1, 2, 3, 4, 5, 6. So the complaints are going to come. It takes all sorts of people. The point is the conversations. The point is the timely conversations. And to see to it that your samne, the person in front of you, understood what you're trying to say. It will not sink in the first time. It will not sink in the second time. So you need to constantly be at it. That's why the palliative care team, the doctor initiates, the nurse follows up, the counselor will keep reiterating it, saying this is why your patient has selected this. This is the reason why he should not be on the ventilator. Unless you prepare the caregivers, I'm surprised and I'm glad that your mamu went through because caregivers, the minute the patient's consciousness level dips, there are times when they completely say, overrule the patient's desire. No, now do everything. It is now my onus now do everything. That's why we need to do this much before and document it. And what we do is involve the family GP, family, patient, and the primary consultant. So that if the patient even ends up in casualty, the primary consultant will be called and said, your patient has come. Then we know immediately we should not do anything because this is what the patient has said. So the loop
So,
has to be closed.
This was actually the irony of it. My mamu was well aware of everything. He signed the documents and everything right in front of her. But the caregiver was not informed. And on the other hand, even if she was, maybe she couldn't process it. But that was the other thing. I mean, how will you help somebody process all this?
Counselor,
Because according
they
to
do
her,
a great job. Counselors do a great job. They prepare the patient. See, you have to explain the medical futility of the situation. Then whatever questions come are existential pains. Why not? But we can afford. We can do everything. Money is not translation into suffering. Na? Money is not going to take away the suffering. Intubation is not going to take away the suffering. So the point is we never budget suffering. We budget everything else. The emotional, psychological, spiritual, financial suffering, we never budget. And which is why I feel very sad that even the rich in the country get horrible treatment because he can afford, karne do, let him endure. Bill is not a factor, no, nobody protests. Somewhere, therefore, I feel in the government hospital, because logic prevails and there is a limited budget, relatives say, I cannot go beyond this. Then at least it's not a right manner of introducing palliative care. Money should not be the factor. So even the rich should be offered palliative care and the poor also needs dignity in death. But the point is, in the country, there's a joke that corporate hospitals, the rich cannot come out and the poor cannot go in. Once they get a scapegoat, everything is done to the patient. And very often we see this, that relatives keep saying, doctors are not telling us only what is happening. They don't inform us only what is happening. And that is something which has to change. It is our right as caregivers and as doctors to inform. We have to be clear, transparent and honest with the clinical condition of the patient. 50% of our problem will be solved if we learn to communicate well. Even in the US, where lawsuits are very high, 90% of the lawsuits are because of poor communication. And when we talk of violence against doctors, it is deplorable. But some things are also because of the way we handle the situation. We cannot be sending an intern to break bad news ki aapka patient mar gaya. It is not on. The senior most on duty has to see to it that the setting is right, make the relatives sit, explain to them and tell. Now tell me which family who's lost a loved one and is grieving wants to go to the court and file case. Obviously, we have irked them so much. Something has happened so much. It's not all our fault. I'm not saying. But we also need to know how to talk and diffuse anger in such situations, which all is a part of communication. And I'm sure you will have it if you've not already had it. It's magical how saying sorry at the right time completely releases the pressure of that situation. And you can then have a decent conversation. There's no point talking to a screaming, yelling relative. You are also screaming and yelling. It's like road rage. Your car will be dented. If two people scream and fight on the road, ek ko to thokna hi hai. So it is just simple as that. It's very important to realize that you can't have this situation. You have to learn to diffuse. And you don't become a less human being by saying sorry. You get your point across better and you hear him better. Communication is very, very important. Sorry, Sridevi. I got carried away, but there's many things here.
No, it's okay.
Shweta
There were
has
a
a
few
drastic
questions
step.
on, there were a few questions on end of life care and DNR, but that will be, I think Dr. Roop will be, someone will be taking that in the end of life care session.
Sure.
And this is a comment from Dr. Shweta. I think
Yeah.
everyone will be able to read it. While Dr. Patmams, can we move on to the presentation for today? We'll start sharing from here.
Okay, ma'am. Okay.
Yes, please go ahead.
Good evening, ma'am, and everyone. Dr. Patnams, working as casualty medical officer in Shivagiri Srinarayana Medical Mission Hospital, Varkala, and also I'm working with a home care service in Trivandrum. I'm really sorry if there is any problem with my voice and network, because it's so that if there is any so I am continuing with my case. 78-year-old male, he was diagnosed with COPD acute exacerbation. He was diagnosed to have CKD stage 5. Hemodialysis was done 5 times. And also CAD, recent AWMA was diagnosed, and PCA was done on 27/21. He was also a type 2 diabetic. He was having systemic hypertensive and grade 1 BPH. At present, he was having the complaints of breathing difficulty, and he was complaining of body aches and headaches and anorexia. Pain score about 4 out of 10. Is a non-case of COPD, CKD, and CAD on regular treatment. Complaints of breathing difficulty for the past 2 days, and body aches for past 1 week. He is not able to walk even a short distance, most because of breathlessness and weakness and tendency to fall on walking. He was able to sit upright. On examination, he was conscious oriented. He was not febrile. He was tachypneic. And he was on the Foley's catheterization. Urine output was there. Temperature was normal. Saturation was 90 at room air. Pulse rate was 80. Respiratory rate 20 per minute, and BP 170. On the auscultation, bilateral lung fields, he was able to hear. Ronchi was heard, and other systems was next. For him, he was treated with the injection Pant of 40 and Hydrocot 200 mg. Stat was given, and advised for the nebulization with the Briolin and BD cut in BD dose, and the O2 was advised 2 liter per minute to 6 liter per minute as and when he was feeling the distressed problem in the respiration. And for the pain, tramadol as stat dose was given, and along with analgesic and NSAID, Dolo 650 was given along with that. And for anorexia, Digiplex syrup 10 ml was given in BD dose. Other investigation for COVID rat was taken. It was negative, and ECG and Tropoy was taken. Tropoy was negative. It's his psychological aspect. He was actually he was looked after by his wife, and his son and daughter was away from him along with the grandchildren, and he's from a middle class family, and he's having a financial constraint, and moreover he's feeling that he became a burden to all others, and he was helplessness. He was in helplessness. Next slide. Earlier medication, he was on ipratropium bromide and levosalbutamol tablets, methylpred, salpidem, Lasix, bethanacol, amiodarone, acidose, atova, aspirin, and vasoglor. Next slide, please. His main concern was he was having multiple diseases, and he was helpless, and also becoming a burden to the family member. And one more complaint he was having, that he was not having anyone to call for help. Next slide, please. So the summary is 78-year-old male and non-diabetic hypertensive with CAD and CKD, presented with acute exacerbation of COPD. Next slide. Here discussion point is the further course of medication, and how judicious we have to use the oxygen and its availability to encourage the community's help, how we can get the community's help, and addressing his psychological aspects and concerns, and also his family's concerns, and most importantly, the assurance of medical support by our home care teams. Thank you.
So now that you have heard the talk and we've had the discussion, how would you have treated this patient differently? I'm flipping it back to you. Any of you, need not be him. This is a COPD. First of all, he's 78. He's got COPD, he's got CKD, he's diabetic, he's hypertensive, he's got a cardiac problem. So he's got a lot of comorbidities. Correct? Of all the comorbidities, what can be really cured? Literally nothing. Not diabetes, not CKD, not hypertension, not COPD, not ischemic heart. So he's really got a lot of non-communicable diseases and all of them incurable at 78. That is the first thing. And like his biggest fear is he's got multiple illnesses. It is true. So if he's obviously worried about it, what would you do next? What should you do next? Your friend has already written. Yeah. So Dr. Ravi Kiran has written, explaining the grave prognosis, avoiding futile care to discuss with caregivers. Excellent. So you need to first, therefore, one of the things is to ask him how much does he know of his illness. He's saying he's got multiple illnesses. You need to emphasize on the fact that yes, he does have multiple illnesses. We will treat all those illnesses optimally, but they cannot be cured. They will progress. So we need some hand-holding with counselors so that he can cope with that. Now, reassurance is a very difficult word. You have to give him realistic hope. Reassurance becomes everything will be fine. Don't worry. We have seen many senior doctors saying, don't worry, everything will be fine. That is something you really need to use cautiously. That is reassurance. What we need to provide is realistic hope. Yes, you have multiple diseases. Yes, it is incurable. We will keep you comfortable, but it will still progress because these are incurable conditions. After that, he's going to feel even more miserable. That is when he needs a counselor for coping skills. Secondly, you need to get the son and the daughter. And in the pandemic, we have got sons and daughters from all across the world on a Zoom.
His major concern was his parting from his son, daughter, and grandchildren.
Yeah.
And also nobody to call. Nobody.
So where was the son and daughter?
Nobody to contact for any of.
So he's feeling. He's not feeling supported. Correct. A palliative care team, a home care team, a family physician is a great support for him because consultants are very busy in the hospitals. Second thing, the daughter and the son also need to know how the father is feeling about them. You understand? So either they make frequent visits or can they take the father to their hometown so that the father can be with them? These are all options you have to explore. It might not be feasible. They might have a small house. They might have too many small children. There might be nobody to care give. So all those things. But these are things, at least the patient feels that you want to help them. You know what I'm trying to say? So palliative care team can do home visits. Family GP can be involved. Daughter and son needs to be told your father is feeling miserable. Can you take the father there? Mother is the only caregiver. She must be stressing. What happens at 2 a.m. if he's going to get up and faint? Mother needs hand holding. Because caregiving is another thing in India. We think it's duty. You have to do it. It is an invisible, thankless job. Nobody looks at the caregivers. Even doctors don't look at the caregivers and say, are you coping? Are you sleeping? Are you eating? It is very important to acknowledge the efforts of caregivers, especially in a chronic illness, because year after year, they are also doing the same thing. It is very frustrating. And it's not, in India, it is considered wrong to complain. If you're looking after an elderly, you're looking after a spouse, it is your duty to do now. If you don't do, who will do? But it is tiring. It is exhausting. So children need to be involved if he's feeling so abandoned about it. That also needs to be, if it comes from a professional, it does make a difference. Can you share the responsibility? Can you come once in a month? Can she come once in a month? Something to do so that the father feels supported. So that is very important. You tell me that did he need oxygen? His resting oxygen was 90 on room air.
At present, he was not given oxygen.
Exactly. So his anxiety levels could worsen the breathlessness. So therefore, physiotherapy, so that he's able to do activities of daily living, counseling, talking to family, talking to, because if he sees his wife stressed, he's going to get stressed. So wife needs coping mechanism, the counseling, very, very important. Then next is, once he's understood the complexity of his clinical situation, then you need to address the futility of aggressive treatment. There is really no point of you going to hospital every time, or ICU or ventilator. Therefore, we will see to it that you are comfortable. If you're affording, yes, go to the hospital, but not to the ICU. Maximum ward care for comfort. But if that is also not a problem, we see to it that the home care team, the GP, keeps him comfortable at home. So money is also saved, family is supported, patient is prepared for what is going to happen, and the children are also involved. So no, we have blinkers when we treat patients. We look at the lung, we look at the kidney, we look at the heart. We don't look at the human. Once you look at the human, you will realize all these aspects come, especially if you have lost or cared for a loved one. You know exactly the issues. The professional caregivers won't come, ward boys don't report on duty, the toilet pan has to be given, that has to be cleaned, diaper has to be changed, bed sore has to be dressed. So if you have looked after somebody, you know, imagine doctors get overwhelmed with all this, imagine non-medicals. So we really need to be supporting to our patients and their families, because they really do go through a lot. Anybody else wants to add something? Reassurance, backup to caregivers.
The
Yes.
caregiver, I think she was relieved giving her contact numbers.
Yes,
And,
there you go.
assured her that you can call 24/7 for whatever help you want. Then she was
Absolutely
somewhat relieved.
And it's not possible to be, you know, again, this is where a team helps, because if not for you, some other team members, some nurses, some social workers, some volunteer, somebody is there at the end of the line. And it's a great relief when somebody picks up the call at 6 a.m. or 2 a.m. and gives you something to do. At least you feel you tried. You know what I'm saying? I have felt that relief many times when I call up my friends regarding my parents. And that liberty I have because of the fact that I'm a doctor. I have friends who can help me. But our patients don't have that. And we really need to be that pillar of support for them, to be there for the patient. Psycho-oncologists to intervene the situation. Yeah. So it need not be psycho-oncologists, psychologists who are trained with end-of-life situations, grief, complicated bereavement, and all those issues. Anything else anybody wants to share or add? I think we have not so bad. We're not overshot time.
No, we have 3 more minutes. So we can take up any questions before we wind up today's session.
Or share a thought or experience.
Yes, Dr.
I
Shweta.
have a question, ma'am.
Yeah.
Not particularly about this case, but then how do we manage breathlessness in this in a patient with CKD? I mean, if not responding to other medications, since morphine is not renal safe, then how to manage breathlessness?
So the reason why CKD patients get breathless is it's a relevant question. Sorry.
Fluid overload. Fluid overload.
One. Most important is fluid overload. Okay. So you can adjust with diuretics. You can control the amount of intake. You can try non-pharmacological techniques, and there is no contraindication to morphine in kidney failure. What you do is reduce the dose, and what you do is increase the frequency. It's not that if it's for comfort, you should give if it's going to make a difference. But then you see to it that you don't give it at the people with normal renal clearance. So if you were going to give him 8 hourly, you can make it 12 hourly. Or if you're going to give 5 milligrams, you can make it 2.5 milligrams. So decrease the dose, increase the frequency, try the non-pharmacological and all that. And along with that, you also, in the past year, we've had a lot of patients of CKD who have said, enough, I don't want to do any more dialysis. And they've said, 4 years I've done it and I've gone nowhere. And every time I go to dialysis, I almost die and come back. So such patients, we've actually started with treatment like Midaz for seizures, inhale spray. We give them anti-itching because they start having a lot of pruritus. We give them a full plan of what to do for each symptom. Like we give them an anticipatory prescription for everything that may happen when you stop dialysis. And we educate the GP and we see to it that the GP gives them the relevant medication at the relevant time, prescribes or injects, and the patient dies at home. So it's not, you cannot give. If the patient is for palliative care and if comfort is important, you just adjust the dose according to the creatinine.
Thank you so much. I totally agree to that. We also have a lot of patients with CAD and CKD. We have treated with morphine, but smaller doses, longer intervals, and they benefit a lot. Definitely, we have to address the fluid overload issues, but after that, it has helped a lot with very small dose, but long. Maybe they need once a day or twice a day, but it makes a lot of difference in their symptoms.
And again, I want to emphasize that communication is important. See, this patient is bad enough to die. Correct? This patient should not suffer before death. So I'm giving the morphine at small dose for comfort. In the process of the patient dies, it is because of his underlying kidney problem. You understand? Communication is very, very vital, because you can have relatives who Google search and say, morphine, why did you give? So the logic has to be explained. The idea is this patient is critical. He will die, but we don't want him to die in discomfort. The only thing I have to give him is morphine. Yes, morphine cannot be given in this dose because of his creatinine. So I'm giving morphine in this dose to achieve the breathlessness comfort. All the time in such patients, you must prepare the relatives that yes, anything can happen at any time. This patient can die at any time, with or without morphine. Agreed. But the point is, with morphine, you will not see him suffer. So I'm giving this dose.
And if they're still seeing their primary physician and relies a lot on his judgment, it's very important to have that conversation. And many times it has happened that I was so scared to call the physician and ask for starting morphine. But the moment you ask all this, they are kind of relieved, okay, because they don't have anything else to offer and the patient is suffering. And then they say, oh, please, if you have experience, if you think that is going to help, please go ahead with the treatment. So if they're still seeing their primary physician, it is very important to just to have a word with him. So that one thing you're communicating that you are seeing other than non-cancer, we are communicating morphine can help in breathlessness, and next time he'll definitely refer a patient with this kind of problems definitely to you. So that's a way of creating awareness among the other specialties also.
Always keep the primary consultant in loop. You try your bit. If the person is too busy, it is not your fault. You either email him, SMS him, write a note to him, but keep him involved. Very important. Like, there is a saying in Hindi that if bad people don't leave their badness, good people should not leave their goodness. So you do your bit. You have only control over your actions. You cannot control other people's actions. So you should try every effort to keep in touch. Then it's really the person in front to respond or not. Shilpa wants to say something. Sorry.
Yes, ma'am. Ma'am, I just wanted to clear it once again. The dose of morphine in breathlessness, like in pain, we are giving it 4 hourly. So here
we started on need basis. So it convinces the patient, the caregivers, and the primary consultant that yes, it makes a difference. Then we start 12 hourly. 8 hourly. If the patient is comfortable, 8 hourly, 8 hourly. Then 6 hourly, then 4 hourly, but never more than 30 milligrams in 24 hours.
Thank you.
Never ever. And it can be given subcute if a patient is not able to swallow. It can be given intravenous, you decrease the dose. It can be given oral. Very often in private, because of the pharma world, a lot of patches are on. But patches in India should be used with great caution, especially in breathlessness, because they will not act as soon as you put the patch. They will take 12 hours. In a country as tropic as India, the sweat hampers the administration. And lastly, you don't know the amount of circulating opioids. So you don't have control. If on the patch, if the patient feels breathless, you don't know how much to give because you don't know how much is circulating in the blood. The control is best if you have given oral or parenteral. You know how much is gone, and you know, therefore, in 4 hours, morphine is excreted.
Thank you.
I had a question.
Yes.
Yeah.
Dr.
So in this country, so in this country where people and patients don't die except at the hands of doctors. how do you practice palliative medicine? For example, if the patients are not from good socioeconomic strata, they might actually end up thinking that you want to pack them off and not do enough for them. How do you sort of counsel
So,
such patients?
it is really your communications doctor. So suppose you have a patient of poor economic, so you always start a conversation with what he or she understands of the illness. So this afternoon I saw a lady of motor neuron disease, 59-year-old, aphasic, cannot talk, unable to swallow liquids, but able to walk. So she had obviously more bulbar involvement. We see a lot of MND patients, and ideally they should be seen by palliative care and the neurologist. The children came with her, and they were definitely of lower socioeconomic society, this thing. And the children knew everything about it because they were young, they're obviously tech savvy, they've read everything about it, and the mother knew nothing. I broke the bad news. So first question to ask is, what do you know about the illness? Bichara, she is not able to talk. She is not able to swallow. Imagine her stress. She has no clue why she cannot swallow. She has no clue why she's not able to talk. So we need to find out first why, what do you think is happening to you? What do you know of your illness? Do you want to know about your illness? If they say yes, you give them, this is incurable, this is progressive, you will worsen. Modern medical treatments will not help you. Aggressive treatments will not help you. Therefore, do you think you want you or your family members to go through that lane? You don't have to make a decision today. Think about it. We will meet again. Mull over it. Send them some reading materials. In whichever the children are at English, so they can read or whatever. Send them some stuff. Send them to a counselor. They will also talk about it. They themselves will come with their decision, and we need to respect that decision. Exact contrast was a 90-year-old lady with diabetes, hypertension, ischemic heart, who had come with left ventricular failure. Her attitude in life, take me to hospital, I will fight. Whatever it is, I will fight. So in that case, now my next session with her is, do you directly ask her, do you want to go on a ventilator? This time you're lucky, you are survived, you're on BiPAP. Next time I will have to put you on ventilator. What are your thoughts? Do you want to put on the ventilator? If she wants to ask me more, I will explain more about the ventilator. After that, if she says she wants to be put on the ventilator, I will respect that. But the point is, we should try. We should not try at all. Na? The idea is, imagine an MND landing up on the ventilator. That bed is gone for 6 months. And that person's life and bank balance, everything will be gone. So our duty is to try. Second, our duty is to give choice. In India, you as a doctor, if you take your parents, you get an extra advantage of being asked, Dr. Satyajit, do you think this is good enough for your mother? Do you think people with no doctor background are asked, what do you want to do? Do you want to take the 5th trial chemo that somewhere in the world is being tried for CA ovary for your mother? Nobody gets a choice. In India, nobody gets a choice. The point is, we have to try as doctors. We should play all the cards in front of the patient. Tell them, this is this, this is this, this is this. What do you want to do? And very often, patients turn around and say, you tell me, doctor, what would you have done? So instead of saying, what I say now when people say this is, I can only suggest. I cannot decide for you. But if you ask me to choose one of the options, I will do this for my kin because 1, 2, 3, 4, 5. Now you decide what you want for your next of kin. Point is, we never try. This all takes time. Because patient will react in one way, then you have to understand, then you have to again summarize. So this takes time and will not happen in one session. Therefore, my request to you all, the best way to start is, all your patients are not going to be having terminal, incurable illness. So the patients who you feel are in that category, take them last in your OPD so that you don't have 20 other people breathing down your neck. Because once you have 20 people breathing down your neck, you don't have the time or the bandwidth to listen to one person's dukhda. You want to see to it that you give him time, allot him specific time. Talk to him, see what his issues are. And then you realize that it will make a difference if you involve a counselor. It will make a difference if you involve the full family. because he will be comfortable. His family is also understood his situation. Unlike that lady who said that her uncle wanted to die in one way, but the family was totally on another page. You can't have that. He was lucky that he was still heard. Many people overrule the patients this thing. So most important thing is to try. And two is to give patients choice. This day and age, none of us wear clothes, shoes, watch, glasses without a choice. Such an important decision of life prolonging, life saving, we leave it to the intensivist we have never met in life before. How does he know my wishes, my desire, my human being, what is important to me? It's such a small thing, but that is the last time that you are going to be looking after me. So please do it my way, no? That is all we are saying. Out of the 10 attempts, now you might fail 9 times, but that one successful time will give you enough confidence and courage to try once more. Like again, Dr. Rajgopal says, first they will all laugh at you. Then they will ignore you. Then they will fight with you. And finally, they will accept palliative care. It is a long journey, but we are not ready to start the beginning only. So that is the reason. So it's encouraging to see so many of you join this course, because all we want to inculcate is the fact that what do you want to do, patient? Tell me, what do you understand of your illness? And therefore, what do you want to do about it? And this is my logical explanation, my experience, and my suggestion. Now you decide. A lot of things will be relieved if patient makes choices. Imagine if a patient comes with you saying, I don't want 1, 2, 3, 4, 5. I want only this. You don't have the headache only, na? Make a bed, make ICU, because we just act like conveyor belt. Casualty, ICU, intubation, ventilator, central line, dialysis, finish. Everybody goes through the same. We need to start putting human feelings, emotions into medical care. That is what is missing, because once we become compassionate doctors, again, faith and trust in doctors are at all-time low. Correct? Everybody, all of us as doctors have experienced this, that even if a relative goes to a doctor in Chhattisgarh or in Manipur, he will call you. My doctor said, take this medication, do this investigation. Is this right, or is he fleecing me? Is it necessary, or am I doing unnecessary? Everybody has gone through this. The only thing that can restore that is the fact that we bring back compassion and empathy into our professions, so that people realize that this doctor cares. Because patients are not bothered about how much you know. They feel glad that you care for them, and that goes a long way. So it's a matter of patience, because all of us know that our businesses, when we start, it doesn't become rocking the first month or first year. It develops slowly. If you have enough compassion and empathy, it still works. So after 5 years, I still make a decent remuneration in palliative care. I cannot say I'm very rich. It is important to earn money, but the satisfaction is also immense. I think my perspective of life and living has changed after talking about death and dying so often. Now I live for the moment. You really need to make the most of what you have, especially post-pandemic.
Thank you, Rajam, for the wonderful.
Thanks. There's
session.
one more hand raised, Vinuta.
Dr. Vinuta,
Yeah.
you had any question?
Hello. Am I
Can you
audible?
just speak?
Yes, very much.
Yeah. Madam, did you feel any resistance from the corporate sector? I mean, clinicians, because it is like we are taking their bread and butter, isn't it?
So not just the hospital consultants are the biggest hurdles. Your colleagues are your biggest hurdles, because corporate hospital success is directly proportional to the revenue.
Yeah.
What they don't understand, Vinuta, is suppose you have a patient, say for example, a 90-year-old dementia, he's admitted with aspiration pneumonia in the ICU, that bed is occupied for 6 weeks. The same bed, if you put a 40-year-old, treat him, he goes back, another one comes. The turnover is much more, because maximum investigations in the ICU happen in the first week. Then it is all CT, some bloods will happen, some this will happen. So what the health economics also works, the one bed with more turnover is definitely more revenue instead of one patient strapping in that bed. That is point number one. Point number two is goodwill. If you have taken the time, like I said, 2 minutes it takes to put the patient on the ventilator. It takes 2 hours to not put the patient on the ventilator. If you have therefore spent that much time with the family, they realize that this doctor is interested in your well-wishing. So there is goodwill and there is word of mouth. So what these people completely forget about the fact is that money is not the one that gets you name and fame. If a patient gets out and says this hospital has a heart, there are going to be more patients coming to that hospital. And to me, I feel like I feel for everybody else. I don't think an OPD with a 2-month waiting list or an ICU which is always full is the best hospital. If you can care for your patients at home and keep them well, they don't need to come to the hospital, right?
Yeah.
So it's how you view health economics. Just because your ICU is full doesn't mean you're a successful hospital. How your patients are struggling there is also important. And how well your caregivers are supported is also important. So one of the hospitals I work in, Hinduja, we have a palliative care consultant taking rounds in ICU because the levels of distress is maximum amongst relatives admitted in the ICU. So we identify those patients and talk to the caregivers and handhold them. Tell me which hospital does that. It's important because it's overall the care experience, right? It's not just survival of your patient. It makes a difference how somebody wipes your patient's back, somebody turns your patient, the way they talk to your patient, the way they address your patient, everything makes a difference, isn't it?
Yes, ma'am.
And we need to start talking also differently, not bed number 302, but Mr. somebody, Mrs. somebody. We very often say patient hai na ILD ka, usko jaake dekho. We have to change and we have to respect each other also and our patients. So many things to learn, small nuances, but it really makes a difference of the total care experience.
Thank you, ma'am.
Yeah, all of you must be late for chai and dinner.
Thank you so much. It was very good discussion. Thank you so much.
Thank
Rajam.
you all. Take
Thank you
care.
everyone for
Bye.
your interaction. Bye. See you next for the next session.
Thank you, everyone. Please don't forget to leave your feedbacks because it is very important for us for each session. With that note, this is Sri Priya along with Dr. Rajam Iyer and Dr. Sridevi signing off from the Tips Eco Hub. See you in the next session. Take care. Bye-bye.